put issues in any questions or anything in the chat, that's great. Sometimes it's hard for us to see the chat in real time. So if something doesn't make sense or something sounds weird, if you're okay to put up your digital hand, if you have that ability to do with Zoom, then I'll answer questions in real time. Or Carla, if I'm missing something in the chat, I might impose on you as well to bring it to my attention. But today we're going to talk about soft tissue trauma. And as I mentioned, I'm a trauma surgeon on the south side of Chicago, Canadian background, dual citizenship with residency in Cuba. So it's a huge privilege for me to be here today with you. Okay. So I think it's important for us, you know, any lecture on any trauma or injuries anywhere gives us as trauma surgeons the opportunity to review the ABCDEs of trauma, even though I'm sure you all know about that already. But then we'll talk about, like, why should we care about soft tissue trauma? How does that fit within our priorities of trauma? And a lot of it is due not because someone might die immediately because some soft tissue trauma, but there are complications related to it. And it's usually complications related to other injuries from other organ systems close by, and also delayed complications that we see. And we'll of course talk about the treatment for it as well. So before we get started, we just want to talk about the primary survey of trauma, like what are your life threats? And let's just maybe go around the Zoom room, if that's okay, for anyone who's able to comment. And Omar, are you able to talk a little bit about what the ABCDEs are, or can you give us the A, what you look for with A?
Yes, sure. The ABCD stands for airway, breathing, circulation, and environment, and D is for the Glasgow Coma Scale. I might have mixed them up a little bit.
No, that's perfect. That's very good. And Mazin or Mohammed, do you want to add anything to what Omar said, which was fantastic?
Yes, I think E also stands for the exposure of the patient sometimes.
Right, absolutely. So we'll go over that, and exposure, especially in a center like mine where we have a lot of firearm injuries, which you may or may not have seen. That's really important because some of the injuries can be missed if you don't expose your patient well enough. So we'll talk about that. So thank you all for your participation. So for airway, we talk about like need to intubate. How are you going to assess the airway? And usually you just ask people their names, like what's your name, what happened? And if they're able to talk to you, they're alert enough, they have good blood flow to their brain, they're able to protect their airways such that if they were to vomit or have something in their airway like blood or teeth, they can spit it out, they can clear their airway, they can make sure that they don't aspirate anything into their lungs. Now, it's interesting when someone is hypotensive, they have a low blood pressure, maybe they have a TBI or traumatic brain injury. If they become unresponsive, they can lose the tone, the muscular tone of their tongue, and that becomes the #1 common obstruction of their airway. So they lie back, the tongue falls to the back of the mouth, and then they obstruct their airway. So we have to do a jaw thrust maneuver, always protecting the cervical spine. But you want to, look in people's airways. If you can, ask them to open their mouth, make sure there's no loose teeth or blood in there. But that's really important. And if someone is not protecting their airway, if you're able to, we always like to intubate those patients. It's a bit of a debate when someone's hypotension because of penetrating trauma, but that's a bit of another discussion for another time. For breathing, there's very little that's a life threat immediately, and it's probably related to rib fractures and blunt trauma acting as penetrating trauma. And they puncture your pleural membrane, puncturing an alveolus or alveoli distally. And then you can have air under tension, which causes a pneumothorax, or blood, a massive hemothorax, or even blood under tension. You can have even a tension massive hemothorax. And both of those we just treat with a chest tube or a pleurostomy tube or a thoracostomy tube. What if I didn't have a chest tube available? What could I do if I was worried someone had a tension pneumothorax, for example? Does anyone know?
A needle decompression.
Sure, let's say I don't have a needle with me, but maybe I just have a scalpel.
Do I turn to open pneumothorax and put the patch to make like a valve?
Yes, what you're describing is now what is frequently described in the latest edition of the Advanced Trauma Life Support book, which is a finger thoracostomy. So I'm going to make an incision through the intercostal muscles, and I'm going to poke through the pleural membrane with my finger, or use the scalpel if I need. And then I'm going to allow air to come out exactly like you said. It's like causing an open pneumothorax on purpose. And it just allows air to come out. Then you can put a three-way valve, like some plastic with tape on 3 sides, to let air come out, but air not get sucked in. So absolutely. So we walk around at the University of Chicago just with a scalpel in our pockets, because that's honestly all we need. There's also blunt trauma that can still cause the same tension pneumothorax or massive hemothorax, because you have those rib fractures that serve like they're penetrating trauma, as if someone has stabbed a patient. But there's also lung problems where you have a big flail segment, and then you develop pulmonary contusion underneath. Not much you can do in the primary survey, just be aware of that. And we use judicious intravenous fluids so that we don't have a whole bunch of fluid leaking out of the broken capillaries of that pulmonary contusion. So circulation, we talk about for and on the floor in terms of all the areas in the body that can lose blood. And we sort of do this cavitary triage in our mind. This is a bit more advanced, you know, more at the resident level. But we do this cavitary triage in our mind of like, if my patient's hypotensive in class 3 or 4 hemorrhagic shock, where did they lose blood? Where is the blood going? And so where would you say, if we go around the Zoom room again, Noor, where's one place where you can lose blood in a trauma patient, or say blunt trauma? Where's one cavity? And Noor, you might not be able to use your microphone, so that's fine. And feel free to put it in the chat. Or does anyone want to give an idea or a suggestion of where you can lose blood? Basically, there's the 4 compartments, and on the floor will be chest. So chest, you can have what we talked about already, a massive hemothorax. And I'll know that by putting a chest tube in and seeing all the blood come out, or putting my finger in and seeing a bunch of blood come out on the bed, on the floor. But then I'm going to have a high index of suspicion of maybe that's the source of blood loss. Also in the peritoneal cavity. So in the abdominal space, I can use an ultrasound if I'm lucky enough to have an ultrasound with. So I can do the FAST, the focus assessment of surgery using, sonography and trauma, the FAST to measure fluid in the peritoneal cavity. And if I can't do that, I can always just do a diagnostic peritoneal lavage, a small incision at the bedside. Or I can always take my patient to the operating room if I have access to do a formal exploration in the abdomen if I have any suspicion. If I don't find anything, so be it, but my patient will still be alive. The retroperitoneum is where you can lose blood, mainly from pelvic fractures. So I can palpate the pelvis if that's causing pain to my patient, if there's clinical instability of the patient, of the pelvis, and the patient's describing a lot of pain with that, then I might be suspicious that there's bleeding into the retroperitoneum. Of course, my ultrasound is not going to help me, because that's only blood-free fluid inside of the peritoneal cavity. This is behind the peritoneal cavity, tracking up from your pelvis. And so The way to know that is through clinical. If I'm able to get an x-ray of the pelvis, if I see a fracture, I'm going to think of that. Or I can go to the operating room again, look into the pelvis and see if I need to do pre-peritoneal pelvic packing, which is, again, a bit outside of this discussion, but something worthwhile to think about. Extremities. I can have femur fractures where, again, the bony edges can act as penetrating trauma and can cause injury to my femoral vein or my superficial femoral artery. And I can lose 1.5 liters to 2 liters of blood in my thigh. And it just requires the person running the trauma, such as yourselves, to look at the thigh. Is one thigh bigger than the other side? Am I losing blood into the thigh? And that's why the patient's hypotensive. We had a case around 6 months ago of a child at the University of Chicago that was waiting to go to the operating room for a femur fracture. And it had somehow been wrapped or casted by the orthopedic surgeons, who then disappeared because they had another case in the operating room. And the patient was hypotensive. And it was hard because no one could assess the leg because it was under casting and wrapping. So we didn't understand why this patient needed blood. Well, we had to take the casting and wrapping down. When we did, we saw that the thigh was huge compared to the other side. And the patient went directly to the operating room because it turns out she had a profunda femoris injury that required suture ligation. So watch your extremities, and also scalp. The scalp is on the floor. And that's because your scalp can bleed like mad. The small arteriolar vessels won't vasospasm shut the way they might on your face or anywhere else in your body. That becomes a big problem where you have to stitch and suture close your scalp lacerations. I've seen people go into cardiac arrest and traumatic arrest from blood loss just from scalp injuries. It bleeds a lot. Then D is for disability. And thank you. We kindly, Omar, went over the ABCDEs. And there's 2 main life threats that we need to identify during D. And you're absolutely correct in saying we need to know what the Glasgow Coma Scale is, because we're using that as a tool together with assessing the pupillary response to see if the patient has a traumatic brain injury that's so bad that the intracerebral pressure is so high that the patient is about to herniate. And that's when the blood pressure goes up and up and up. But then at the end, it starts to crash down. It goes up, it goes all over the place because the brain is herniating down and down the foramina magnum. And that is a life threat for which we give hypertonic saline and call our neurosurgeons if we have access to that support immediately. Or the other cause of life threat in D is neurogenic shock from quadriplegia. Maybe a patient fell on their head, they have a cervical spine injury that's high, they can't move their hands, they can't move their legs, and now they have an interrupted sympathetic chain going to their heart, so they're bradycardic, going to their blood vessels, so they have no vascular tone, so they're very vasoplegic. So that's a life threat as well. What do? Well, we blame low blood pressure, any shock, on bleeding until proven otherwise. And then once I've ruled out all the other cavities of bleeding, then I want to make sure someone has vasopressors. It's the only time we use vasopressors. How am I going to pick up a spinal cord problem in D? Is after I've assessed my Cs and I'm assessing my D, I'm going to assess the GCS and the pupils. Oh, good, the patient's not herniating because the GCS is over 8. They're not comatose. So that's fine, no herniation. Now for the spinal cord, then I'm going to ask the patient, squeeze my hands, push down, and then push down with your toes on my hands, pull up with your toes on your feet on my hands. I want to see if they can move their hands and move their feet. If they can, unlikely to have quadriplegia, even more unlikely to have neurogenic shock. And then, like we mentioned, exposure. Men, women, boys, girls, all trauma patients, and we have to roll them early and make sure we're not missing a penetrating injury. There's a famous case at the University of Miami of a 14-year-old boy that was transported to the trauma center, And the story wasn't clear. He fell from his bicycle. No one really knew what was going on, but the paramedics kept his clothes on. Then he came in. But then when he came to the trauma center, he was in traumatic arrest. He was dying in front of our eyes. And then when we took his t-shirts off and everything off, we saw a tiny small wound in the middle of his abdomen, right underneath his chest in his xiphoid process, because he had actually been shot in his abdomen, which is why he fell off his bicycle when he was shot. And that was missed, and he ended up dying. So you need to expose your patients, and once you've done that, keep them warm with any blanket or anything you might have available. So I don't care about soft tissue injuries as part of my primary survey, because a soft tissue injury will not acutely kill my patient, but that's something that I care about in the secondary survey. While I'm looking for vascular compromise, open fractures and compartments, and all of those things are important as part of my secondary survey. So again, if your patient is hypotensive, it's pretty unusual to be soft tissue trauma when it's an acute injury. Now, if you have a patient that's being transported to you and they've been under the rubble for 24 hours, 48 hours or longer, they could be hypotensive for soft tissue injuries. I am talking about someone that has been hit by a car, someone who has been shot, someone that's experienced a blast injury or crush injury immediately as part of your primary survey. Unusual to be related to soft tissue trauma unless there's a delay. So again, soft tissue trauma can be very important because I'm going to look for injuries that are more serious on deeper levels. And so that's really important. And why is that? Because I want to make sure I'm not missing anything. But even soft tissue trauma in and of itself can have complications that lead to life-threatening conditions. It can cause occult or hidden ongoing bleeding that I don't know about. It can lead to infections, including necrotizing soft tissue infections, which are again are life threats within hours. The tissue can, once it's infected, can die as well. And a lot of these injuries are dirty infections too. And it can cause crush syndrome, which we're going to talk about and why that's important. So these soft tissue injuries and complications can actually lead to serious disability if they're not treated adequately. And disability is an important thing. So you want to rule out vascular compromise in the torso. Again, this is sort of part of our foreign on the floor. You're looking for the hemorrhagic shock that's related to your primary survey. So we already talked about pelvis, you're going to have your retroperitoneal hemorrhage. But in addition to vascular compromise, you can have other tissue injuries. I'm going to be worried about extraperitoneal rectal injuries in the pelvis, vaginal injuries for women, bladder injuries, and just perineal soft tissue injuries. So those are injuries that are problematic, but they're not going to kill you immediately. They're not going to cause problems immediately. In the abdomen, after my primary survey, I've done my FAST, I've done my diagnostic peritoneal lavage, I've looked in the abdomen, there's no free blood, but a seatbelt sign, if I haven't operated, if I see a seatbelt sign maybe across the abdomen, which is just bruising underneath where the seatbelt might be, I might be concerned about, is there a jejunal injury? Is there a small bowel injury that might declare itself days later or even hours later? So what other intra-abdominal injury is going on with that? Is there a chance fracture of the spine because of the flexion mechanism of getting a seatbelt sign? You can also have seatbelt signs across your neck, for example, if you have a thoracic belt and an abdominal belt. So you have to be careful if you see that bruising along the neck, or in cases of strangulation, you can have injury to your common and your internal carotid arteries, and it can cause intimal flaps. So think of blunt cerebrovascular injury, as they're called. When someone comes in, you see a bruise on the contralateral side, they're unable to move their extremities. And what about extremities? What about if there's vascular compromise? Of course, not a life threat. No one's bleeding out from an extremity that's undergone amputation or something. And maybe I do even have distal pulses. Well, we teach the brachial index and the ankle brachial index, because this is actually something that helps diagnose and rule out injuries of the blood vessel when you're not bleeding to death. You still have injuries of the vessel. And this is sort of more in line with vascular surgeons or trauma people that will look at the extremities, and probably not very, very relevant now, but still important. And again, penetrating soft tissue injuries can still cause serious muscle bleeding, and that might actually need direct suture ligation, exploration in the operating room. So even though it's just muscle bleeding, it's not something I would find in the primary survey. I still want to be aware of it because it can actually keep bleeding. So let's say I do have someone come in and they have life-threatening bleeding from an extremity. So there's a Stop the Bleed course that's largely for penetrating trauma. And penetrating trauma doesn't just have to be a bullet or a stab wound. It can be from like a piece of wood. It can be from damage from like fence or any debris or anything going on around, anyone that's experienced a crush injury. So if you see an extremity that's bleeding actively, you have pulsatile bleeding, you need to engage in direct pressure. And you can put direct pressure with a t-shirt, with anything that you have nearby. The patient will die if you don't apply direct pressure. So just with your hands, direct pressure. Be careful, don't cut your fingers if there's a piece of glass on the inside, if there's a piece of metal still on the inside. You need to be careful you don't injure yourself or create more injury for the trauma patient. So apply direct pressure with your hands. If you can't do that, you need a tourniquet. And the blood pressure cuff is actually the best tourniquet you might have. So you might have some paramedics close by. If you're going to make your own tourniquet, that's the subject of a completely separate talk I hope you'll get access to. You're really going to have to make sure you do a proper tourniquet, and not just a tourniquet that's strong enough to stop the venous blood flow from the back, but strong enough to stop the arterial blood flow from going in, or else people are going to die because you're going to have more loss of blood with more venous blood flow coming out. So it has to be above systolic pressure. So your blood pressure cuff or your tourniquet has to be 180 to 200 millimeters of mercury of pressure. And again, ABI or BBI is probably beyond the scope of this lecture, but it'll help us diagnose injuries to blood vessels that might require follow-up. So don't worry about that too much, and I'm happy to give more information to anyone who has more follow-up questions on that. So again, you can have a combination of blunt, penetrating, or crush injuries that lead to soft tissue compromise and bleedings. Bleeding, and any layer of bleeding can occur, especially muscle. And I just want to say a note on this. I know I said that you just need a scalpel, you can do a finger thoracostomy with a scalpel. You do have to be careful. Normally, when we have the luxury of having all the equipment we need to do a tube thoracostomy, how do we get through the intercostal muscles? Do we cut through the intercostal muscles or even the subcutaneous fascia with the scalpel? No, because that causes a lot of bleeding. Because remember, I mentioned healthy, viable muscle will bleed because it's very well vascularized. We want to put a Kelly in and we spread the muscles. It's exactly like when we're doing an open appendectomy, we spread the muscles. We never cut across the muscles or cut through the muscles, we spread. Now, in cases of emergency, like someone is dying of a tension pneumothorax and I can't poke my finger through the layers, I'm very happy to cut through there. And then I'll deal with the bleeding after, because that person is going to die from a tension pneumothorax immediately. So it's just something to keep in mind. And sometimes, as I mentioned, you might actually have to go looking for the bleeding vessel in the muscle. It could be a named vessel in the muscle. I've seen stab wounds to the deltoid muscle, to the pectoralis muscle, and pectoralis major artery might be bleeding or something like that, where you have to go make the incision larger and suture ligate whatever is bleeding. And just be careful. You have to be careful not to just suture the skin closed over top of your injury, because then you will continue bleeding underneath that. Now, infections are another complication of soft tissue injury that are very important. But let me pause there just for 2 seconds to see if there's any questions that anyone might have so far. I see the chat looks fine there. Any questions from anyone? And feel free to just sort of call it out if you need to, or you can put up your digital hand. Oh, okay, fantastic. So you might have heard when people talk about infections, clean, contaminated, dirty. That's really when we're talking about surgical site infections. And so we can apply the same principles, if you will, to soft tissue infections or infections your patients present with. For example, it's not going to be unusual, unfortunately, for people being collapsed under the rubble to present with dirty infections because they've been contaminated with dirt, and also there's hours that have gone by, and so that shifts it from contaminated to dirty. So we consider all soft tissue and injuries are considered dirty because they're not made under sterile procedures by a sterile scalpel. It's made by metal, rocks, debris, something in the outside world, which are not sterile. And often, again, dirty if there's a presentation for surgical or a delay in presentation for surgical care. So especially with the puncture wounds that are deep, you want to worry about tetanus and think about Clostridium. We'll talk about that a little bit more. And then the principles of treatment, which of course we'll talk about as well, extensive irrigation and debridement of infected or devitalized tissue. And again, the big principle is you never suture closed a dirty wound, no matter how clean it looks. I've irrigated it a lot. You never want to do that because you're going to just cause a nidus of infection, because no matter how much I irrigate, I haven't been able to sterilize the cavity. And if I haven't been able to sterilize, and I know there's bacteria left behind, even though it's less, it's a lot less than it was before. If I close that cavity, it's just going to form an abscess, or worse, it's going to form a bad infection, a necrotizing soft tissue infection. So you want to maybe close the wound loosely, but allow some packing and dressing on top, and that's going to seep up and absorb all the seromas and fluids that tend to build up, because any fluid that sits there in the wound, it has sugar, because we have sugar in our bloodstream, we have sugar in all the fluids in our body, and it's warm because of our body temperature. Bacteria love sugar and bacteria love warmth. So it's just like an agar plate for bacteria to grow on. So we want any fluid to be absorbed and whipped out, and we want to change our dressings. We'll talk about that later. But again, with any infection that you're dealing with for the first time, or any infection you're following, if it looks like it's getting worse, if there's pain out of proportion, we'll talk about this as well, you're always asking yourself in your mind, is this a necrotizing soft tissue infection? Do I need someone more senior than I am to come and look at this infection? Do I need help? Do I need to call one of my colleagues? I don't have anyone more senior than I am to look at this infection with me. So how do you classify necrotizing soft tissue infections? You notice I don't call it necrotizing fasciitis, because that's just one layer, and you're able to have any layer of tissue die, hence the necrosis in the name. And if it dies, it means no amount of antibiotics will prevent infection from setting in. No amount of antibiotics will heal the tissue. The tissue is dead. I need to use my scalpel to remove it. So it's a surgical infection, and we need a surgeon's scalpel. So for example, I might have necrotizing cellulitis, different from regular cellulitis, where antibiotics alone are not going to treat it. I have to remove the skin. Necrotizing fasciitis, it's the subcutaneous fascia. So Camper's fascia, Scarpa's fascia, it's really that subcutaneous fat. Sometimes people call it subcutaneous fat, but the official name is subcutaneous fascia. It has a poor blood supply, and infection spreads very quickly. So that's commonly what we see. So we need to see if I have to debride that layer as well as the skin. What about necrotizing myositis? That might be when my muscle compartment is violated and the muscle is dead. or osteonecrosis, when the bone is also dead as well, and the orthopedic surgeons have to debride the bone. So I don't care what the layer is. Basically, I'm going to keep cutting until I see healthy tissue. What is healthy tissue? Good blood flow. Hard to see on bones, hard for me to diagnose osteonecrosis. Any chunk of bone that is no longer attached to the main bone and it's just sitting there floating in infection, I'm going to discard. I'm going to get rid of. For fractures underneath, open fractures, they're going to need antibiotics. But I'm not going to worry about imaging. I might not even have imaging. I don't use imaging in Chicago because it doesn't help us at all. The only thing that helps us is our scalpel. And what we do is what's called the finger test for necrotizing soft tissue infection, which you can see here. And this was something that has been very helpful in countries that have experienced earthquakes, multiple crush injuries, the earthquake in Haiti, for example. All you need to do is when you have pain out of proportion, my apologies for the phone in the background, pain out of proportion to the exam, the patient is screaming in pain when you touch it, when it looks red, or you have some swelling as well. And crepitus, that sort of gas you feel under the tissue, that's only present in 30% of cases. And it's only present also in 30% of cases too when you're scanning people. So I don't scan people. So the finger test has 100% sensitivity, meaning if it's negative, I know my patient does not have necrotizing soft tissue infection. So it's very helpful for that. But a positive finger test is all of the three things here. Lack of bleeding in the subcutaneous tissue, dishwater fluid, and tissue dissection with minimal resistance. Okay. And any questions about that so far? Okay. So the other thing is crush injury. And that's different from crush syndrome. Oh, wait a second. I might have a question. Do we suture the wound? That's an excellent question, Mohammed. Mohammed and colleagues, what do you all think? Should we suture the wound closed after doing the finger test? Omar, what do you think?
I think we should apply open. Say the wound should stay open because it's an area of necrotized tissue full of bacteria, other than applying my finger, which might be contaminated. So that's my opinion. Might
Right.
turn to
Right, absolutely. So if my finger test is positive, all the tissue below is dead. It's not bleeding. I have that dishwater fluid coming out. Then I know, for example, that I am going to the operating room and I'm going to do a wide extent of all that dead tissue. The finger test is just to tell me, should I go to the operating room or not? If I don't need to go to the operating room, chances are there's already cellulitis on top. There's already some infection because the skin is red, but maybe antibiotics alone will be fine. And it's not a necrotizing infection, necrotizing soft tissue infection. So I don't need to go to the operating room. However, it's still an infected wound. So I agree with that. So all we do is we apply just a dry dressing on top. And then we just change that every 24 hours and just let it heal by secondary intention on its own. And you can do what's called wet to dry infections, which are cheap and effective. And you basically just put sterile saline on your dressing, put it on top, and then change it every 24 hours. Okay. Any questions? Any other questions about that?
yes. Do I apply hyperbaric oxygen?
So that's a great question, Omar. So for some cases of necrotizing soft tissue infection, when you have an infection with Clostridium, which is not 100% of necrotizing soft tissue infections, that's really the only case where there's evidence to suggest that hyperbaric oxygen will help. So you don't have to do it as a matter of routine. And in fact, we haven't even sent anyone at the University of Chicago for hyperbaric oxygen therapy, even though it will help heal your wound faster, because it's so few patients that have the isolated Clostridium infection. Normally for us, it's a lot of polymicrobial infections and patients with diabetes. And so there's no good evidence that hyperbaric oxygen will help in those patients, for example. If you have it, I would say there's no downside, but keep in mind it doesn't help all necrotizing soft tissue infections. Yeah. Any other questions? This is excellent. Okay, excellent. So we'll carry on with crush injury versus crush syndrome. So, you know, anything syndromic is sort of the whole body has a problem. Anything with an injury is talking more about like a local problem, for example. And so a crush injury is, again, the local problem, local injury caused from physical crushing of the muscles due to something heavy like rocks, anything, destruction of a building, anything that goes on top of a person's leg or something. Crush syndrome is when the crush injury has caused so many problems on a cellular level that it's affecting your kidneys, it can affect your heart, and a whole bunch of different things that we will talk about. Complications for crush syndrome include hypovolemic shock. Now, do you remember at the beginning, I said, oh, it's impossible to have low blood pressure and be in shock because of soft tissue. That's true acutely. But if you have people that are coming to you and they might present in hypovolemic shock because they've been under the rubble for hours to days, if they're still alive, okay? So that's because you have, like, as I say here, loss of plasma volume, you have damaged cell membranes, and you have basically your capillaries are leaking fluid and third spacing. So, and this can lead to also myocardial depression because you have a lot of intracellular electrolytes that are released. So you have absolute abnormalities of potassium and calcium. And also you can still have blood loss, like slow going blood loss from injuries as well. So keep in mind, if you see a delayed patient present like this, we've had patients trapped under rubble and in cars for bad motor vehicle collisions in Chicago and also Miami, where we actually try to start to give them IV fluids while we're still extricating them and trying to remove them from whatever they're trapped underneath. So again, some of the electrolyte imbalances, hyperkalemia and electrolyte imbalances, you can have disruption of cell membranes. And when you release potassium because of that disruption, that can lead to cardiac arrest. So something we like to do is give calcium intravenously as something that can stabilize the cardiac membrane. So when we have sequestration of plasma calcium into the injured tissues, you can also get a relative hypocalcemia. That doesn't help me with my clotting abilities, and it doesn't help me with shock. And you're going to have a huge metabolic acidosis as well. Compartment syndrome is also a problem because of the crush injury. So you can lose the entire viability of all the muscles in specific compartments with that. So that is important. We'll talk about this also as well. And then acute kidney injury because of, you have the rhabdomyolysis because of myoglobin being released by injured muscles. The myoglobin is directly nephrotoxic. And so that causes acute tubular necrosis leading to rhabdomyolysis. And you stop producing urine in addition to being pre-renal, having pre-renal failure because of hypovolemia in general. But this is really, really problematic where you need a whole bunch of intravenous fluid to ensure an adequate diuresis to clear out the myoglobin out of the renal tubes. But often patients will need dialysis, which is hard. So basically, crush syndrome overall will look like something like this, where you have the prolonged compression of skeletal muscles, and then you remove whatever is impinging on the legs or the arms or the torso. Then you have a wave of electrolytes that go back into circulation and cause a lot of imbalances, especially cardiac arrhythmias, hypovolemic shock, and things that will be life-threatening. And not immediately, like within the first minutes, the way blood loss can be, but it can after hours to days for sure. So any questions about that? Just going back to crush syndrome. Have any of you
Yes.
seen? Yo, go ahead.
I have one question, just. I've
Omar.
read about crush syndrome, and they said that it has a very poor prognosis because there's a influx of electrolytes that may lead to sudden death. So if I have a crush syndrome, what would be the perfect step? Do I amputate or not?
That is a great question. It depends whether you can remove the patient from the debris. So one question is, do you amputate in order to be able to remove the patient under the debris? Or the other thing that people can do is, as I mentioned, if you have a way of starting intravenous fluids and pre-hydrating the patient before you remove the block or whatever is crushing on them, or while people are still working on removing the block, you want to give them as much crystalloid fluid as you can so that they start to urinate, they start to have that on board. If you can give them calcium, you know what you're going to have. If you can get calcium where they can have cardiac stability from the increased potassium that will come back. Or sometimes what you might want to do is, if you're unable to do that in the field, you can also put a tourniquet or blood pressure cuff around the leg. Let's say it's a leg that's being crushed, but you're able to free the leg, put a blood pressure cuff around that. And that way you can release the blood pressure cuff, release all the toxins back into circulation in a controlled fashion at the hospital once you've already established IV fluids. I think it's an excellent question, Omar. You want to be careful about just releasing the debris off the legs, for example, if you have no IV access. You might need to do that, but your patient can go into cardiac arrest for all of these reasons. So if there's any way that with paramedics or anything, you're able to start fluid in the field and just pump them full of fluids, that's really the most ideal situation. Any other questions? Okay, we'll continue. Blast injury, I think, is important to talk about because it can cause soft tissue trauma. And also, unfortunately, there's lots and lots of blast injury that you're seeing and people are seeing in Gaza right now because of all the bombs that are being dropped by the IOF. So this is physical trauma caused by the rapid pressure wave and associated fragments generated by an explosion. And I'll talk more about that. But blast injury is different from just a crush injury because there is a blast wave that compresses the air, and it can lead to hearing damage to your internal organs, damage to your lungs, damage to structures that have air on the inside. And even though outside, someone might look fine, they don't have cuts or anything on their skin, but on the inside, there is a lot of internal organ and internal debris. And then there's a secondary injury that can occur by projectiles and debris that we'll talk about. And it depends on the type of bomb that's used, if it's small, if it's large, depends on how close you are to the blast. But it can indeed cause significant soft tissue trauma. So here's a diagram of what that looks like. So that primary blast injury, that cavitary injury, can affect your lungs, tympanic membranes. Many times patients can't hear what you're saying or telling them, or bowel perforations. And then there's a second negative pressure wave where it sort of sucks a lot of free flowing debris, loose debris back towards the patient, the site of the explosion. And that can serve as penetrating trauma and cause further injuries to your patients. And then there's also people are going to be thrown, they're going to fall, they're going to have things fall on them that are large and can cause crush on top of blast injuries. And there's burns, also including like fire burns and chemical burns and other concerns that we have with that. And it's because of this peak pressure, peak overpressure, that causes that blast injury, and then that negative phase, which sucks all this free flowing debris back towards the patient at the site of the blast. And so that's very, very important to understand that. So even though the take-home message, even though your patient on the outside might look intact, they might have significant injuries on the inside. So soft tissue injuries, what are the principles? So one thing is you want to make sure that you're safe. And it depends whether you're extricating someone from an unsafe area. There's still aggression going on, and the Israeli military is still attacking people. You are the next generation of healthcare providers. You're the current generation of healthcare providers. You have to make sure that you're safe as well. Something that's very important as well is I remember operating once on a patient that had a saw injury because they were working at home with some wood, but half of the saw broke off inside of their abdominal cavity and lacerated their aorta. But we had to pick the saw out with our fingers, and that could have easily cut our fingers. And so you need to make sure you're safe when you're going into people's wounds. Remember with Stop the Bleed, if there's anything bleeding, you need to apply direct pressure. Your fingers are in the wound. Make sure you're not going to cut your fingers. And there's transmission of hepatitis A, B, C, D, E, many hepatitis, HIV, all these things, but you also don't want to cut your fingers. If you cut your fingers, it makes it hard to operate. It makes it hard to take care of other people. So just be careful that you're safe, because that way you can help the majority of people around you. Remember your ABCDEs in all trauma patients. And of course, attend to the life-threatening injuries first. Then after that come the limbs. If we need to amputate limbs to remove a patient out of a unsafe situation, so be it, as Omar was asking about. But see what you can do to save the limbs if you can, as long as there are no life threats right now. And then the idea is any devitalized, infected, and necrotic tissues, the best friend you're going to have, again, as I mentioned, is your scalpel. And I might need to debride or remove that necrotic tissue several times. Antibiotics are important. It really depends on what kind of bacteria are growing in the area, but basic coverage will include even penicillin intravenously. And you want to think about tetanus, especially for deep puncture wounds, and give anti-tetanus immunoglobulin if you have access to that, or tetanus toxoid to give a booster for tetanus. So that's important too. But to be honest, if I have no access to antibiotics, I'm going to still use my scalpel. And the most important thing I can do is debride using my scalpel, remove all the dead and infected tissue. And also any loose foreign material. So that's important, whether it's foreign because it's a foreign body, like, you know, any like metal or debris, like rocks or dirt. I want to remove that. Or also the other thing that might happen is I might want to remove any loose bones or any tissue that is no longer viable. So really don't fear your wound. You want to sharply remove anything that's dead. How do I know what is dead or what is not dead? If it is bleeding, you have to be careful, because sometimes the tissue might look pink and might look healthy. But for example, when we go to the butchers, or if you see meat, you might see meat that's pink. It looks healthy, but it's not meat that is alive. You have to cut into the muscle, the skin, the subcutaneous tissue to know if it's bleeding or not. And if it's not bleeding, it has to come out. And again, watch any tissues that have retracted, because you want to really make sure that you get all the muscle, especially that might be necrotic, might be no longer alive. So it has to be pink and bleeding. And then you might need to pack the wound for hemostasis after. If you have small bleeders, you can suture ligate them with under a clamp, and just make sure the bleeding is under control, because you need to see good bleeding to know that you've done an excellent debridement, but you want to make sure you control the bleeding too. So it's a bit of a catch-22. So small bleeders, you can tie off with absorbable sutures or any sutures you have, frankly. And then after that, you also might just need to pack the cavity for hemostasis. And then you want to change this. You want to change your dressings every 24 hours. And you want to be careful. And I'm sharing some material with you from the World Health Organization about, and the International Committee of the Red Cross, about war wounds. They talk about not packing the wounds. That's largely because you never want to lose a piece of gauze on the inside. If you're going to pack for hemostasis or for anything, make sure it's one piece of gauze or one piece of packing, or you have to tie the packing side to side so that you just have to remove one bit of packing. If you lose a gauze inside of the wound, that's going to be a source of sepsis for the patient. That could kill the patient even. So that's very important. So surgical debridement, if you have local anesthetic, that would be very, very helpful. You might need to use conscious sedation if you have access to this. Ketamine and midazolam is a good combination. That's very important. It can actually really alleviate the pain. Here is a QR code if you have access or able to use your cell phones. You can look at the video from this QR code on how to do surgical debridement. And Carla will have this for you. You'll have all of my slides. So you want to prep and drape in the standard sterile fashion, and you're going to sharply debride all layers. If you can maintain as much as skin as possible, that's good. Subcutaneous fascia is not well, it's not very perfused. So you want to make sure that you remove it because it has a propensity of dying quite easily and becoming necrotic. The muscle, again, cut into it to know if it's viable or not. Tendons, if you can preserve them, that's important. And you want to make sure they're moist afterwards. And the fascia of the muscle that sits on top of the muscle too, you might need to debride that. Again, you're ligating small bleeders for hemostasis. And then if you're needing to debride the open wounds and soft tissue wounds of your legs or any extremity on your arms, for example, your hands, your feet, your gluteal region, your thighs, you might need to decide, does this patient need a fasciotomy, yes or no? And so that's important. Before we talk about that, though, I want to talk about the dressings. If you're putting a dressing on top, you're going to need to change the dressings every 24 hours, but it's very likely you're going to need to repeat the debridement every 24 hours at the beginning, because you're going to see how far the necrosis spreads, how far the infection spreads, and you want to make sure that you incise and extricate it and you remove all of the dead tissue. That takes more than once in the operating room or at the bedside if you can use ketamine and midazolam at the bedside. So have a low index of suspicion of going back in, especially if your patient changes their clinical status. And you never want to suture your wounds closed. Again, we talked about that because your wound is still contaminated. You're going to let it heal by secondary intention with packing and changing your dressings. We like to change our dressings twice a day. Wet to dry, it goes in wet, it dries, you remove it. That's the old-fashioned way that we have, that we still use, of removing the extra bacteria as well. So once I'm happy I don't need to remove any more tissue, then I can do this and it keeps the wound clean and it allows it to heal from secondary intention. If you're fortunate enough to have access to vacuum-assisted closure devices, those are very helpful too, and they need to be changed every 3 to 5 days. But that's, again, only once I know that the wound is completely clean and totally debrided. So when talking about fasciotomies, that's worthwhile to have in an orthopedic or in another lecture, but I do want to mention it because it is an important point. You need to do complete fasciotomies. And so this is a slide from one of our international trauma courses where you can appreciate that the fasciotomies were too small. were inadequate, and this does not decompress your muscle compartments of your lower extremity, for example. This is the example of a lower extremity fasciotomy. Excuse me. And again, for your lower extremity, you have 2 skin incisions, but there's 4 compartments that you're opening. And on your lateral incision, you're opening your anterior compartment and lateral compartment. At your medial end, you're opening your deep posterior compartment and your superficial posterior compartment. And the deep posterior compartment, you need to bring your soleus muscle off the tibia so that your neurovascular bundle can be freed. And it's your anterior compartment at your lateral incision that's the most frequently missed. And so you want to open that up, and we'll talk about that here, where we tend to teach doing this H incision in your anterior compartment and your lateral compartment. And you do a crosshatch, a cross cut here to make sure you open both compartments. We've had recently, and this happens in a lot of other institutions as well, where you can actually open up two compartments, but the anterior compartment can be mistaken for your lateral compartment, and then your lateral compartment can be mistaken for your posterior compartment or your superficial posterior compartment, which you actually open on the medial side. So you sit there in your mind, you're like, hey, I opened up both compartments, that's great. Well, this is where I think we should do something different, where I think you should do the same incisions where you have your one skin incision with your landmark being your thumb in front of the fibula, and you're making an incision down from the tibial plateau down to your lateral malleolus. You want to make your incision along your anterior compartment and your lateral compartment, but then instead of doing one cross in the middle, you're doing a hashtag in two locations, and these lateral incisions touch the tibial bone itself. That way, you're going to know that you'll have opened up this 1 centimeter compartment that's very easy to miss. And so no compartments will be missed that way. So to wrap it up and leave it open to questions, I'd love for all of you to remember, as you know very well, the ABCDEs of trauma. It's important to remember that soft tissue trauma can also lead to many complications. And soft tissue trauma generally is something I'm looking for in my secondary survey, because with acute trauma, it's not something that's going to kill your patient initially. So it can cause bleeding of the muscle, infections, and sometimes my infections might be a necrotizing soft tissue infection that can spread extremely rapidly and can kill my patients in a matter of hours. I'm worried about necrosis. I'm worried about crush injury turning into a crush syndrome. And also, blast injuries can cause soft tissue infections and soft tissue injuries. So I want to think about them, even though my patient after a blast injury might look fine on the outside. And treatment is surgical debridement with my scalpel blade. And I might need to do that several times to ensure that the tissue is healthy and clean before I allow it to heal by secondary intention. And here is a QR code, again, if you want to download the PDF on war wounds and the surgical management of war wounds from the International Committee of the Red Cross. And I'm very, very happy to answer any questions that you might have. And I'm going to stop sharing now. And again, you'll have access to all these slides. Thank you very much for your attention. Are there any questions right now? Okay, if there's no